and we are having the Association of Spine Surgeons of India webinar series, which is based on the common topics in practice. Also, we will be covering up a lot of topics which are very interesting and challenging at times to orthopedic surgeons, spine surgeons, and neurosurgeons all across. This is an initiative which is supported by the Association of Spine Surgeons of India. I would like to thank Dr. S.K. Srivastav, sir, who is the president of ASSI. I would like to thank Dr. Appaji Krishnan, who is the secretary of Association of Spine Surgeons of India, and team ASSI for this wonderful education initiative. And also, I would like to thank our stellar faculty and my co-convener, Dr. Abhay Nene from Mumbai, who is a constant source of inspiration to us. And we have stellar faculty in this webinar. We have Dr. K.V. Menon with huge amount of experience of around 35 years with us. We have Dr. Rajesh Parasnis from Pune, who is again a stellar faculty and a knowledge-based surgeon from Pune who does a lot of work in complex spine surgery. We have the famous Dr. Bhauk Garg from AIMS Delhi, who is known for his innovations and his deformity surgeries all across. But Dr. Bhauk Garg does lumbar spine surgery also. He does disc surgery also, and he has a lot of experience on dealing with these problems. We have Dr. Parthasarthi Srinivasan from Chennai. We all know him. The spine circuit knows him as an Iron Man who does very much fitness work. At the same time, he's a phenomenal spine surgeon. He treats a lot of athletes, and we will know conservative line of treatment from Dr. Partha. We have our own executive committee member, Dr. Fani Kiran from Chennai, who will be dealing with a little bit different topic, this which is a foraminal extraforaminal disc, which is a challenge to orthopedic and spine surgeons. How we deal with this is a challenge, and Dr. Fani will be enlightening us on this topic. We have Dr. Arjun Dawle from Reliance Hospital, Mumbai, will be talking on large disc when it comes to the clinic, whether we need to immediately consider surgery, whether we need to consider a decompression only, or we need to think about we need any fusion or fixation. This is a very interesting topic again, and Arjun with a large experience of his practice in India, and he was trained in America. I think it will add up a lot of insights to all of us. Also, we have two interesting topics. One is by Dr. Dr. Akash Singh Bali from Delhi AIMS. He's a fellow in All India Institute of Medical Science. We'll be talking about nowadays different things which we talk is disc surgery, whether it is open surgery is good or microscopic discectomy is still a gold standard, or endoscopic or minimally invasive. This is always a debate in all spine and neurosurgery conferences, and he will enlighten us with the review of literature. At the same time, Dr. Parsha, who is a Association of Spine Surgeons of India's National Fellow, will be talking about some interesting facts and historical perspective about the disc disease, which is a very old problem, and back pain is very common for all orthopedic surgeons. We treat around 30 to 40% patients with back pain, and disc is always there. So all these things really will add up, and Dr. Ajoy Shetty also will be online with us as he was traveling, but he will also share his words of wisdom in whether we need any fixation. This will be jointly shared with Dr. Appaji also, with his large expertise practicing at Apollo Hospital, Chennai. Will share whether when we consider fusion, when we consider fixation, and this will be a very interesting and interactive webinar from the ASSI. So I would like to thank once again to all the viewers from all across the world for supporting us. The Ortho TV team, the spine surgeon himself, Dr. Ashok Sham, who is my dear friend, who was trained in Korea, and he is the founder of Ortho TV, and Dr. Neeraj Bijlani, who is also a dear friend from Mumbai. We trained together, who are instrumental in supporting this venture. And I would like my co-convener, Dr. Abhay Nene, to say a few words before we continue.
No, thank you, Shailesh, and thank you for bringing up this entire webinar series, which we plan to approach daily, everyday problems, but give it a new twist because no two discs look alike, no two lumbar stenosis look alike. So the simplest problems can be your biggest undoing, and we see that again and again in practice. So if you see today's topics, there will be all the red flags that revolve around something that looks very easy. So thank you for bringing this topic back to us, Shailesh, and let's introduce the first speaker.
Yeah, thank you, Dr. Nene. And I would like to invite our secretary, Dr. Appaji Krishnan, to welcome the webinar to all the delegates and faculty. Over to you, Appaji, sir.
Yeah. So I'm in a, dinner meeting. So sorry if my internet is breaking. This is a brainchild of Dr. Shailesh, and I said go ahead, and this should be a nice venture. ASSI is all supportive of the new ventures we do. So this program will be monthly, and I invite all the participants to enjoy what's happening. Welcome all.
Thank you, Dr. Appaji. And we move on to the first presenter, Dr. Partha from Chennai. Partha, it's all open to you, and you're the opening batsman of the ASSI Spine webinar series. Over to you, Partha.
Hi. Thanks, Shailesh. This was a very interesting set of topics that we're doing. And let's start with the simplest thing, the lumbar disc, the most common thing we see. Now, normally, if you get a 35-year-old with an acute low back pain for 5 days, and somebody usually jumps up to take an MRI before they come to us, and that MRI shows us a disc bulge. Somebody else advises 6 weeks of complete bed rest, and this patient comes to you after 6 weeks. Now, what do you do? The patient still has back pain, but then we need to be very clear that all acute low back pains are not disc prolapses, even though the primary treating doctor would have said this disc bulge is the cause of your pain. And most acute back pains are self-limiting. If you've ruled out the other issues and the red flags, then we can treat this in a more positive way. But then when we're talking about a lumbar disc prolapse, we're talking about specifically a unilateral or bilateral radicular plane where the leg pain is more than the back pain. There are nerve root signs, and there may or may not be neurological deficit. Ruling out Waddell signs and MRI confirming the level and the side will give us further clarity on what it is. The criteria are pretty much the same as what McNabb said. You need to have the leg pain, which is the predominant complaint. You may or may not have neurological symptoms. You may or may not have root tension signs like an SLR or a bowstring, but you will have neurological signs corresponding to the single nerve root that is involved. So when as a rule, I generally do not ask primarily for an MRI with a patient who has a classical signs of a disc prolapse without any neurological deficit. Usually an MRI should be ordered if there is a neurological deficit or if there is surgery being considered. Now, most of the time we end up having a patient come in with an MRI like this, a pretty large disc compressing the left side L5 root, very common picture. Now, when do we decide to operate? So in my mind, there are only 3 reasons to operate. One, if there is a cauda equina syndrome, then that is an emergency. 2, if there's a profound neurological deficit that is more than grade 3 in that specific nerve root. And the third one is a pain not settling with conservative management. And in this case, when our indication is pain, that the decision to get operated lies with the patient. So only the patient can tell you whether their pain is too much and they're not able to handle it and they require a surgery. So for 90% of patients with a lumbar disc herniation with acute sciatica, you will see significant improvement within 6 weeks, and a lot of them will resolve by 12 weeks. This is the natural history. Now, what constitutes conservative management? You can rest is one of the things, medication, physiotherapy, and injections. This I would put into the conservative management area. Now, what is the rationale for rest? Technically, it decreases mechanical pain and intradiscal pressure. But how much rest? I remember when we were postgraduates, it was always like 6 weeks of complete bed rest. But this is no longer the case. Bed rest in excess of 2 days is not associated with a better outcome, and continuing to perform activities as tolerated leads to a more rapid recovery. 6 weeks of complete bed rest is completely out of the picture now. Now, painkillers as a treatment, do they alter the course or the speed of resolution of the pain? No, they don't. But they definitely do keep the patient comfortable till nature takes its course. So definitely you need to use opioids or NSAIDs depending on your practice or depending on the patient's medical comorbidities. The other thing that we use a lot is gabapentin and pregabalin. These drugs definitely decrease the amount of neuritic pain, though they do not alter the course of the resolution of pain in a disc prolapse. They do give significant relief, especially in the early stages where the chemical irritation of the nerve because of an acute disc prolapse is the most important component of the pain, and it's less the compressive effect. Systemic corticosteroids. This is something that a lot of people tend to give, but systemic corticosteroids have definitely got no better effect than placebo for a lumbar disc pain. So you can stop giving systemic steroids in a case of an acute lumbar disc. Short-term outcomes with pain relief like TENS and ultrasound, they improve only short-term outcomes. There is no evidence for traction. So using it as a method of holding the patient in bed or as a method of trying to get the disc back into its place has no value whatsoever. So traction, I generally do not advise. Immediate strengthening exercises may not be a very smart move, especially if a patient is in pain. There will be significant muscle inhibition, and this can, of course, be needed to start off once the pain settles down in 3 to 6 weeks. Epidural steroid injections have been given before, but they for a unilateral radicular pain due to a disc, they are not much better than a placebo. Caudal epidural catheters have also been tried, but for a unilateral disc, they do not have much work. The best thing to attempt in case a patient has a lot of pain and still comes to you within the first 3 to 4 weeks is that I usually advise them a selective nerve root block, which targets a single nerve root, usually fluoroscopy or ultrasound guided, can be given by anybody who knows how to do it. Usually, I do it myself. A relative contraindication is having a bleeding diathesis. There's a lot of support and evidence for the use of this, and I tend to use it whenever there is a unilateral, predominantly radicular pain, which is quite severe and not settling with analgesics, but the duration is still short. These are the requirements. You need a dye, you need some local anesthetic and the steroid. You can use Depomedrol or Kinocort. Either way, you need to make sure that you're usually in the axis that you use, you will not hit CSF, so it's not too dangerous to use either steroid. This is the pictures of an L5 root block. You can see the AP images where the needle is just lateral to the pars and heading in underneath the pedicle on the lateral view. Then you can outline the nerve root with a little bit of a dye and then inject it. In an S1 nerve root block, we would choose to go through the first sacral foramen, and again, we will be able to outline the nerve root and inject it. In this patient who had a previous fusion, again, they had a disc at L5S1 and this was causing pain, which relieved very well with a nerve root block. This was an old series of my patients who had undergone that, and a lot of them, 80 to 90% of them resolved completely, and very few of them come back for a surgery. These are the recommendations, but they're just listing out what all I told you in the previous slides. How often can we conserve? An acute lumbar disc prolapse, conservative management is effective 90% of the time. And if you have a recurrent episode after a little while, the chance of still conserving is still 50%. If you get a third episode, probably you may need to advise surgery earlier. In conclusion, I would avoid continuous bed rest. I would not recommend traction. Analgesics and pregabalin are useful in the acute phase. And selective nerve root block is extremely useful both diagnostically and therapeutically. It's also a very good holding procedure for people who don't want surgery. Now, one of the things that you must understand, or at least I have seen in my practice going forward, has been that my operative rates for disc prolapse has dropped considerably. In fact, it is true that 90% of the patients who come to me with a disc prolapse, even if they've been advised surgery before, usually maximum get a nerve root block. Thank you.
Thank you, Partha, for a wonderful presentation. And I think you opened the shots very nicely. I would like to ask Dr. K.V. Menon, sir, who has practiced since a very long time, and when probably MRI was also not there, probably sir must be seeing the X-rays and CT scans. What is your take, sir? How different it was when you started your orthopedic practice?
So there are two things I want to address. One is the question that you asked, and the second is some of the points where I agree and disagree with Partha's talk. Regarding the question which you asked earlier on, at one time we were doing myelograms, and then when CT scans became available, our diagnosis was based on CT scans, and then eventually when MRIs became available, we started using MRI scans, and obviously MRI scans are the gold standard. The numbers of disc prolapses that we operated were far less than what it was today with CT and myelo, of course. With MRI, I think the numbers have actually increased, and unfortunately not always for the genuine reasons. That's the first part, the answer to your question. The second part is I want to highlight 3-4 points based on what Partha said. One is discogenic pain. The pain source in a disc is based on something called Allmarker's hypothesis. Allmarker says there are 4 sources of discogenic pain. First is the mechanical compression of the disc on the nerve root, which is just about 25%. The second is the chemical irritation of the nucleus pulposus. Nucleus pulposus has got a lot of chemical irritants, and specifically, in addition to the interleukins, one specific protein, phospholipase A2, is a remarkable neural irritant, and that is present in the nucleus pulposus, and that is responsible for the chemical component of the discogenic pain. Third is a vascular component. On the nerve roots, you have vasa nervorum, which get compressed, and that produces lactic acid accumulation in the distal part of the nerve, and you get an ischemic pattern of pain. And lastly, and not the least, you get DRG sensitization. This happens in the subacute and the chronic discs, not in the acute disc. So all 4 together are important in producing a discogenic back pain. Therefore, the chemical element, particularly due to phospholipase A2, is best addressed with SNRB, the selective nerve root block, with steroid. Even systemic steroids are proven to have exactly the same effects. Whether you administer it systemically, whether you administer it locally, it gives you the same effect. That's been my experience. Now, the third point I wanted to highlight based on what he said was, he said that 90% of the discs are managed conservatively. This is entirely true. The only problem is, number one, the age of the patient. Number two is the level of the disc prolapse. If you have an L4-5 and an L5-S1 disc prolapse, 90% are treatable conservatively. Whereas if you have an L1-2 or L2-3, L3-4 disc prolapse, it is very unlikely that they'll get better with conservative treatment. Similarly, adolescent or pediatric disc prolapse almost never get better with conservative treatment. These are just 2 comments based on the talk. But very well done, partner. Whatever he said was essentially good. Thank you.
Thank you, sir, for your words of wisdom, and that's what we want, someone with this huge amount of experience. But I must compliment Partha for covering a whole aspect of the conservative treatment, which is constituting the maximum, and not all disc problems are surgical. And thank you. We move on to the next. Any take on this, Dr. Abhay?
I think one question, Partha, before you go away is what is the role? What is the percentage of new neurology coming up in a patient who's on treatment?
It's like usually if there is neurology, it comes pretty early on, and I mean it signifies a significant amount of compression. And one of the things is that we need to look carefully at what is the neurology. If your neurology is a grade 4, it depends on what level you're discussing, right? At an L4-5, a grade 4 is not so much of a problem. A grade 3 is also not so much of a problem. But if you're dealing with a L3-4 disc or an L2-3 disc where there is weakness of the quadriceps for whatever reason, then a grade 3 is a disability, and you may look closer at it in terms of wanting to operate earlier. Progressive neurological deficit usually is associated with a lot of pain in the early stages itself. So if you have a patient who's really in a lot of pain, then take some time with examining the neurology.
And is there any truth in the fact that, or the belief that early surgery helps neurological recovery better in case of a disc prolapse with neurology?
If you have the indication to operate, yes, earlier is better. I mean, if you have a grade 2 or a grade 1 power, then you want to go in as soon as possible. I think Dr. Menon has something to add.
There's some published evidence which says that the best time to operate a disc is within the first 9 months. If you delay it for whatever reason beyond 9 months with your conservative treatment and Ayurvedic trials and various other things, then the results progressively go down.
Perfect. A
Perfect.
great discussion. Maybe we should move on in the interest of time. Thank you, Partha.
Yeah.
Thank you.
We will invite the Association of Spine Surgeons of India's fellow, second year fellow, Dr. Parth Shah, to share his screen and share his interesting facts about the disc. Yes, over to you, Partha.
Yes, sir. So, good evening, everyone. So, I'm Dr. Parth Shah, a second year ASSI fellow. So, before we discuss where we are today, so it is essential to understand where it all began. So, let's explore the evaluation of the lumbar disc disease and its management. So, it all started in the book of treatise of the predictions of the Hippocrates, where he first described the word sciatica from the Greek word ischios. So he described it as a cramps and cold in the loin and the leg. So the disease, he said, would last for 1 year, and where young people it would get rid of pain in 40 days. So this is the line which all the modern surgeon we have to learn in our lives. So the first in the 18th century, the Domenio Contugo distinguished the arthritic sciatica from a nervous sciatica in 1764, and it is the first. He gave the name Contugo syndrome, which stood for 100-150 years, which is the first one to name the sciatic and link it with the spinal disease. Before it, it is all the related to the hip syndromes. In the 19th century, Dr. Rudolf Virchow, the father of the pathology, he described the disc pathology and how the ruptured disc will cause the chemical reaction in 1832, which is all Dr. K.V. Menon sir has said. It is still relevant that the pain described by the disc rupture is because of the chemical reaction. In 1864, the Lessig test and the straight leg raising test was introduced by the Lessig, uh, Christopher Lessig. So it distinguishes the sciatica from the hysteria, and it is one of the most important tests which we are still using today. And so on the literature, what we have find is that the 1901, the first laminectomy and the disc fragment removal was done by Hermann Oppem and Professor Cross. They are the German professors, and they are the neurosurgeon who does the first laminectomy and the disc fragment removal. But the main modern pathology of the disc will change with the landmark paper of the Mixter and Barr from the England. They have performed an lumbar discectomy and making the preoperative diagnosis of a ruptured disc. And for 2 years, they have operated around 100 to 150 patients of lumbar disc herniation with laminectomy and discectomy. And they published a paper in 1934, which is one of the first paper, which is the rupture of the intervertebral disc with the involvement in the spinal canal, which is the first described paper for the sciatica and the disc prolapse. So this work transformed the lumbar disc herniation from a speculative explanation into an accepted surgical and diagnostic entity. So in 1938, Professor Love and Walsh describe an interlaminar extradural approach which minimized the unnecessary bone removal and became a standard of the open discectomy. So subsequent decades show a preference of more radical disc removal, and as the later experience showed, the excessive disc clearance contribute to the disc height loss and persistent back pain. From the 1970s, a more limited strategy which was focused on removal, offering a fragment rather than an aggressive evacuation, which is increasingly favored. So this is an important conceptual shift, and the objective of the surgery will become disc removal. Objective of surgery will become a neural decompression with preservation of spinal structure rather than removal of as much as disc as possible. And it is the modern concept where all the micro discectomy, endoscopic discectomy will be done, on this concept, and the refinement of magnification, illumination, and retractors further supported this less disruptive surgical approaches. So the history of lumbar disc herniation is the story how sciatica evolved from a symptom-based diagnosis now into a surgically and biologically defined disease. Thank you so much, sir.
Thank you, Parth, for this interesting and historical aspect. I'd like to ask Dr. Arjun, what is your thinking about the presentation?
So I tend to conserve a lot of patients with lumbar disc disease, and only really the absolute indications or patients who really have significant functional limitation, with radiological correlation and with predominant radicular symptoms or deficits are the patients who I will offer surgery.
Okay. Bhauk, I would like to ask you, in 1930s also they have mentioned interlaminar. So how it was, in that time they must be doing autopsy. What is your take on the evolution?
So I was born in 79, so 30 was not an issue. But yes, I did a lot of literature review because my thesis was the first, the experience of microendoscopic discectomy. So Professor Jaiswal started it, and I was the first to do in India in 2001. So we started this whole, about the history and everything. We did a thorough review of literature. And yes, the Mr. and Bars work was the most, the famous one. And they actually thought it was some fragment or something, and they didn't expect that it was actually disc. And when they sent it for histopathology, actually, then they came out to be knowing, yeah, that some sort of, this material. And then, this whole procedure started. So yes, doing autopsy was a major thing. And I think now people have again started realizing the importance of autopsy, especially in the unusual pathologies. And now there is something called the virtual autopsy has started at AIMS also. They get their CT scan and the MRI in the mortuary. So they have a separate facility. And I think they are able to pick up, so many newer findings, why people are dying for some unknown causes.
Thank you, Dr. Bhauk Garg. And I'm keeping Dr. Rajesh Parasnis as a reserve for the next topic's discussion, as that's also a very interesting topic. I would like to invite Dr. Funny Kiran from Chennai, one of the finest spine surgeons in Chennai and a stellar performer in minimally access surgery. Would like to invite Funny to share his screen. Dr. Funny.
Yeah, hi. So just a second, let me share the screen. So foraminal disc is something one needs to be aware. It's not as common as the protein disc prolapse, but it is something that can be missed because the symptoms are not as classical as what we find in regular disc prolapse. So let us just, I'll just show a case example. This is a 35-year-old man. He's a IT professional who came with severe left side radiating pain going down the left leg for about 10 days. He was not able to walk even a few steps, and he was walking only with a forward stoop and keeping his thigh flexed, only a few steps. And it was an acute onset pain progressing and making him almost bedridden, shooting type of intolerable pain. He was the pain, he said, also increased on sitting. He was not even able to sit. So only thing he could do was just lie down. Even with the lying down position, he had significant pain. He did have some symptoms about 4 months back, which started like this, but he was managing with medication and he was getting better and going on. But then this last 10 days, suddenly there's an increase in pain. He's a chronic smoker, but no comorbidities. On examination, we found that he had this forward stoop and flexed posture of the hip, unable to walk even few steps. And there is a list also to the right side. And there is a decreased sensation over L5 on the left side, and any movement of the leg was quite painful. EHL was weak on the left side. This was his X-ray. And this is a standing X-ray with a significant list noted, and also the loss of lordosis. And the MRI. Now, when you look at the MRI, or the initial look at it, you'd find there's not much of a significant disc, but when you look closer in the last axial sections in the lower and the parasagittal on the left side, there is a significant foraminal disc. There's a small foraminal bulge at L4-5, but the actual culprit is what was happening at L5-S1, where there is a significant L5 root compression if you see the parasagittal on the left side compared to the parasagittal sections on the right side. So the left side L5 root is completely pressed against the pedicle, and there's no space in the foramen at all. So this is the common appearance of a foraminal disc. The reason it gets missed again is two reasons. One is the symptoms are many times atypical, not matching with the typical SLR and relieved by rest, and the nerve stretch signs sometimes can be vague. And second thing is the MRI, it is sometimes very subtle and things get missed quite easily on the MRI. So this was the diagnosis. So I would just like to pause here and open some discussion if anybody wants to.
Yeah, we'll ask Dr. Parasnis. Yeah.
What was the reason for his hip flexion, you feel? Hip flexion weakness on the left side, you said?
The weakness is only on the EHL. There's no weakness, but he was keeping, when he was walking, he would keep his hip in flex position and a forward stoop. On examination, the hip joint itself was normal. There's no in lying
deficit.
down.
Yeah, you just mentioned grade 4, so fine. So there is a foraminal disc and extraforaminal at 4-5. Now we know that the foraminal disc at L5-S1 can cause the ganglionic compression, so the pain is much more severe. So there are two ways to manage this. In the absence of significant deficit, you can definitely give a nerve root block for diagnostic confirmation where the pain is coming from, and also for the relief. But if you feel that a patient is not going to tolerate a long time pain and the pain is very severe, you are perfectly justified to do a decompression. For the foraminal decompression, a transforaminal approach, endoscopic approach is one of the best, or you can do a extraforaminal approach with a tubular retractor. But you need to study the anatomy when you're approaching L5-S1 very clearly. The iliac crest is very high, then you will be forced to go through the interlaminar area, and sometimes over the top from the opposite side will be a better approach.
Yeah, perfect. Partha, any take?
Yeah, so the only thing here that we have to worry about is because it's an L5-S1 extraforaminal disc maybe going on a transforaminal approach with endoscopically may be a little bit more difficult. But again, I don't do endoscopic, so I would do the second approach where there would be a tubular retractor and I would go through a Wiltse kind of approach.
Perfect. Let's hear from Dr. Funny. What did you do?
So foraminal disc, I will just briefly for the understanding where it is exactly. It is in the foraminal zone, as you can see here. It's quite lateral to the traversing root, and it goes cranially and impinges on the exiting nerve root. It impales it against the pedicle, and it's a very sensitive area because there is the dorsal root ganglion there, which is quite sensitive, and the inflammation around the dorsal root ganglion can be very painful, and that's the reason they have many times significant sensory symptoms like burning electric shock-like sensations, which are a little bit atypical. So these are the treatment options, like we discussed. One is an open Wiltse's approach between the multifidus and longissimus, which can be also done through a tubular retractor or the endoscopic techniques. Why do we need to go lateral? Because the routine interlaminar approaches may not be able to reach lateral enough. Going into the foramen may involve compromising the facet and may not be able to reach far lateral. So that's why the Wilsey's approach, a plane between longissimus and multifidus. And then one needs to remember that there is a thick, significantly strong membrane there, the intertransverse membrane, which is covering the exiting nerve root. And once that is elevated, we can see the nerve root and the disc prolapse, which is compressing. And this is how the Wilsey's approach exposes the area. You can use a tubular retractor or even an small open approach to reach that area with a microscope. We did a transforaminal approach. Of course, the reaching L5S1, which is deep down into the pelvis, is difficult. But the good thing is, in a extraforaminal disc, you don't need to go very horizontal or because you don't need to reach into the canal. So you can start closer to the midline. Even about 7-8 centimeters lateral to the midline is enough for a extraforaminal disc. Only when you have to go into the canal, reach the paracentral disc, then you need more horizontal approach, and that would make it difficult at L5S1. So this was how this was done. I'll just show small clips, which you can see on the left side. The thing that is going along the left side of the frame is the exiting nerve root, under which we are working to release the prolapsed disc fragments. It is quite a tight space. One needs to be very careful. Even in endoscopic approach, it is very difficult sometimes to identify the nerve root. So one should not cut or displace things without exactly finding where the root is. So what approach I always approach it from the pedicle, the lower pedicle, which is very safe to land on, like you can see in the images here. Land on the lower pedicle and then find the pedicle and then work your way upwards into the foramen. So first thing you would encounter is the annulus or the disc, and the root is further cranial. So this is how the disc fragments were removed. The extruded fragments, it is quite a bit under pressure, and once it starts coming, you can see that it just pops out most of the times. And another important thing is the amount of disc that comes out most of the times is much larger than you would expect, even from the MRI. And it is not a commonly operated case. I've done only 4 or 5 of these in the endoscopic approach. And always the amount of disc I found is much larger than what we would expect as well from the MRI. And then that is when after the disc is completely removed, you can see that the exiting nerve root is quite free and mobile. And he had a good relief, was able to walk within a couple of hours without the forward stoop or flex hip, and he was discharged pain-free the next day. Thank you.
Anyone has any comment? Any of the faculty? Yeah, I think I really liked the way you tackled the situation. And see, it's all we want to conserve, but at times when the patient's pain is also a very, very important aspect. If you are not getting relieved with conservative treatment, giving painkillers and things like that, I personally feel somewhere there is a role of a pain block or a decompression. Even in acute early phases. That's in very, very selective patients. Yes, of course, we always try for a conservative treatment. But this is a very, very special approach and very, very minimalistic, very nicely done, Dr. Fani. And we move on because we'll get some additional questions in between. I would like to invite Dr. Arjun Davle for a similar topic, a large disc. How do we manage? Whether we do only decompression or we consider fusion, or what's Arjun's take? Over to you, Arjun. Yes, we are.
So I'm going to start with the case, and I'll request one of faculty to comment. So a 31-year-old female complaining of left lower limb radicular pain in 6 months. and she had weakness of the left ankle, dorsiflexion, ankle jerk, management, and not manage her work and develop this deficit. So how would you approach this? And what are the factors you're looking at on the X-ray and
Yes,
MRI?
Dr. Parasnis, Dr. Menon, sir.
Substantial neurological deficit, and we need to corroborate with the size of the disc. Also, sometimes with the age, weight, and professional demands of the patient. So not every time you can just prolong your conservative treatment. Looking at the size of the disc, the kind of foraminal compression, and the deficit, I will counsel the patient very properly. Only if they are very reluctant to operate, I will offer a prolonged conservative treatment. Otherwise, a minimally invasive discectomy in such cases will give a very rewarding result both for the patient and the doctor.
Yes, thank you. So that's what was offered, and that was what was done for the patient. And the patient, has improved post-operatively, and it was done, microscopic discectomy, and the patient has improved. Now, I wanted to ask you about, the prognosis for the recovery of the, weakness in the foot. In terms of temporal changes, if a patient comes to us, within a week, or a patient comes to us, after a few weeks, does that affect the recovery of the deficit?
Yeah, see, Dr. Menon sir has already mentioned that 6 to 9 months is a period beyond which it's a compromised result. So obviously, if you're going to operate earlier, the better. But in terms of weeks to months, there is no data to say that it suddenly changes in a shorter duration. Another thing that I forgot to mention are the modic changes and mild retrolisthesis. So a lot of people do tend to feel that if there is a large central disc with modic changes, you need to go and stabilize. But that's not a point of discussion over here. So I think that till 6 to 9 months if the patient presents with this kind of deficit, we are justified to do decompression for neurological recovery.
Thank you. So I'm going to go to the next case.
Yes. Some internet issue.
Right hand.
Yeah.
And positive. Sensations are present. Left jerk was absent. This is the X-ray and the MRI. Again, comments. Different case. Had higher disc here. There's a very large fragment. You can see that's a very large fragment. It's actually obliterating the entire canal.
Yes, Dr. Funny.
Would it differ, or would it be similar?
So this is a higher lumbar disc, and there's a significant compression. Right ankle, plantar flexion, left ankle. So it's bilateral weakness. So it's a cauda equina compression. Is there any
no bladder involvement? Means was checked, but
any other image, Arjun?
The duration is.
So this is the video. I'm showing you the video now.
Yes.
You can see the large disc. It's exactly at that level. 3, 4.
Okay.
You can see the facet joints also, and
Yes, Dr. Funny.
So this is a significant large disc, and also causing significant neurological deficits. And what's the duration, Dr. Arjun? Duration of symptoms?
This patient had only 10 days. 10 days history.
10 days history.
Yes, only 10 days.
So even then in a higher level lumbar disc with significant weakness, which is causing significant disability, I would consider an endoscopic discectomy in this particular situation.
Okay.
Interlaminar endoscopic is what I would consider.
Menon, sir. KV Menon, sir.
So I have a completely different take between this and the previous case. This is an upper lumbar disc prolapse, and there is no sequestration. So these 2 points make a huge difference. Upper lumbar discs generally land up in surgery eventually, and sequestration is the one thing that is amenable to conservative treatment. The previous case was a lower lumbar disc, and it appeared to be fully sequestrated. A fully sequestrated disc can resorb. And usually in 6 months, if you take sequential MRIs, the disc you will find is completely resorbed if it's a sequestrated disc. So my indications for surgery in the first case was a little bit less. I would definitely have tried conservative treatment in that case. But in this case, no, I would definitely suggest surgical treatment.
Perfect. Let's
What
see
surgery, sir?
what surgery.
My surgery is a MILD, minimally invasive lumbar discectomy. It's a foraminotomy, flavectomy, and discectomy. I use a light source retractor with interlaminar approach. No endoscopy.
Okay, perfect. What did you do, Arjun?
That's what I did. So I did a microscopic lumbar discectomy, decompression interlaminar, and the patient did improve. Okay. Now, the third case, this is an older patient, back pain, leg pain, SLR positive, neurologically deficit, and this is more of a superimposed. No.
Okay. MRI is not come. I think there is some lag.
What are the
of-
considerations?
Yeah. Would like
Can
to
you
ask
see it?
Appaji is around. Yeah, Appaji.
Yeah, Shailesh.
What is your take on this? 70-year-old back and leg pain, SLR is positive, nil neuro.
Yeah. So
Has been on considered for long.
if he
Has
is
tried a block.
more of a claudicating pain, I am a fixer. I will actually do a TLIF for this patient.
Okay. Dr. Akash Bali, what will you do?
She's an old patient, so there's back pain, there's leg pain, there seems to be canal stenosis, LCS, and degenerative listhesis at 4-5. I think if the patient has significant back pain, then fusion would be better for this patient.
There is a
4-5.
lateral listhesis of L3 or 4. So will you go up to L3 or you'll just do L4-5?
So we'll need to see the upper sections as well of
Yeah.
the canal stenosis, left canal stenosis there for that.
Dr. Appaji, will you do L3 to 5 decompression and 4-5 TLIF or L4-5 only?
I will prefer to do only L4, L5. No other decompression is required. You can do whichever way you are trained, but it should be a reduction or no reduction, but decompression and fusion.
Dr. Bhauk?
Yeah, Shailesh, so I think we need more information as a degenerative listhesis. So nowadays we get a full routine workup in these cases, and if there is a mild scoliosis as well, which I can see. So I normally order a whole spine X-ray as well, sending to look at the overall alignment, and we follow the MISDEF algorithm, MISDEF2 algorithm. And we also get a flexion extension views to look at the actual amount of instability. So if there is no instability at the L4, L5, maybe we can just get away with the decompression only. But if there is, the MISDEF type 2 or 3, then probably we will need fixation in these cases.
Yeah, we got the answer from all. And let's see what Dr. Arjun Daule has done. Arjun.
This patient was treated with a single level fusion. I bring this up because I want to highlight the facetal effusion. The facetal effusion on the MRI, which you can see. Okay.
Yeah.
And that is a very important the facet sign which one should look for on all scans. Also, apart from the disc, looking at the ligamentum flavum hypertrophy. So if there is a very obvious facetal effusion, then that is an indirect sign of instability. And of course, it has to be corroborated with a standing X-ray. Sometimes patients who are in a lot of pain cannot cooperate for a flexion extension film. So you can look at the dynamic supine MRI versus the standing X-ray.
Perfect.
So
Let's hear from Dr. Appaji. Yeah, you want to say, yeah, Arjun?
No, we can. We can go ahead with the comments, please.
No, this is also important recurrence factor.
Yeah. So now basically when we are looking at treating the lumbar disc, so obviously conservative treatment works, most discs resorb, and on a minority of patients require treatment, and finally we're not treating the MRI, we're treating the patient, the functional limitation, the problems which are encountered. But if we are deciding to go ahead with surgical treatment, then one needs to be aware that there is a recurrence risk of 5% at least, if with whatever treatment modality we offer. And one needs to look at getting a good history, looking at the clinical comorbidities, smoking, smoking environmental factor, which we have to tell patients to stop. Diabetes, obesity, high BMI, we're seeing more and more often, younger age, and male sex. These are some of the clinical, factors which are more in favor of a recurrence.
Yeah. Shailesh, can I make comment?
I'm bringing up the radiological.
Yes. See, the last case, what Arjun has shown, I would really term it more like a stenosis and an acute or chronic radiculopathy. The approaches will be vastly different
Yes.
since we are talking more about lumbar discs over here. So differentiating between claudication and a recent radiculopathy or only radiculopathy will be entirely different. I'm sure most of the panelists will agree with me. If it is a recent radicular pain, many a times it settles down. But if it is a significant claudication, they usually require decompression. And the minute you have this kind of radiological picture, facetal tropism, facetal effusion, signs of instability, trefoil canal, scolioticum, and lateral extrusion. So then with decompression, you need to stabilize. But this is primarily a degenerative listhesis stenosis, not just a disc. That's the only take I have.
Perfect, Dr. Parasnis. Thank you for your insights. And Arjun, I think it was a very good mix of different cases. Again, you scored very high on your presentation. In your time, I would like to ask Dr. Appaji. He said he's a fixer, he likes to fix. What is your take up, Dr. Appaji? Which all are cases in the disc pathology you prefer to stabilize? When you prefer to fix? Because I know you do a lot of decompression. Appaji.
Yeah. So whenever there is a term which Dr. Hegde learned from his boss, Dr. Chopin, called cascading spine. Here you can see two of those discs which are degenerate and all those things. So we have a criteria. So decompression is only when they have central stenosis, no foraminal stenosis, no lateral recess stenosis. If we have to do lateral recess de-roofing, removing the facet and other things, we go in for a fixation. And if the disc height is maintained, patient is younger, and if there is facet trophism. So these are cases where I will go for a fixation. If it's pure central canal stenosis, pure claudicating pain alone, bilaterally equal, and it's in the MRI showing only central canal stenosis, I will do a decompression alone with the disc height reduced, disc settling down. Yes.
Okay, perfect. And what is your take, the presenter Arjun? What is your take on this?
No, I mean, basically the NAS guidelines where, very clearly say there's insufficient evidence to make, for fusion, lumbar fusion and treatment of lumbar disc herniation. There's not enough evidence actually. So probably, more fusions are done than necessary. And I'm just going to basically go to, the last couple of slides. So if it's a large disc, when would you do a discectomy? If it's a primary disc, if it's radicular symptoms, if there's a deficit, if there's no instability on X-rays, if it's a soft disc, facetal tropism, but without any associated, signaling facetal fluid. And of course, if it's a medical, a lot of comorbid conditions where you don't want to go ahead with a fusion. And when would you consider a fusion? Then a recurrent disc, ideally a second recurrence, but, can consider it in first recurrence. If there's definite instability, facetal effusion. If it's a congenital stenosis with a high lumbar disc, because then approaching that becomes, you're going to have to retract a lot, or you may injure the pars, or destabilize, by removing the facet. And the others then are kind of relative, So again, we have very senior people here, so they can give their take on this.
Thank you, Arjun. I think it was a wonderful presentation. You covered a lot of topics, and I think only this can be a half-day webinar on this particular topic. You try to summarize in a very short and swift manner. In the want of time, I would like to move on with the next presenter. I invite Dr. Bhauk Garg we are talking about conservatism, talking about surgeries, but what if there are problems, and these are also very, very important. Over to you, Dr. Bhauk, on adverse events and complications. When there is a problem while doing surgery, it's called as adverse event, and when there's a problem, it's a complication. And Bhauk is no other better guy than Bhauk for this webinar. Over to you, Bhauk.
Thank you, Shailesh. So you have already said that complications will be more with me. So
No, not like that.
So
The expertise needs for this
Just
talk
joking,
is very
just joking.
challenging.
So the complication of disc surgery, nowadays there are so many methods and so many types or ways to do the disc surgery, ranging from open to microdiscectomy, tubular endoscopic, and each procedure has its own unique risk profile. So we must understand that the complications do not mount to failure, but they are basically some system gaps. The aim remains that you should anticipate, and then you should mitigate them, and you should salvage them. And your focus should be on the high impact, low frequency events. And we also know that these complications, they impact outcome, medical legal risk problems, patient satisfaction, all they are affected by these complications. And we should also know that, certain patients and the certain pathologies and certain surgical, the scenarios, they are prone to risk. So if there is a obese patient, if it's a smoker, if the diabetic patient has diabetes, if it is a migrated disc, if it is a calcified disc, and if the surgery is a revision and if there is a multi-level pathology, then obviously the chances of complications are higher as compared to the other factors. So these things should be kept in mind. So I am classifying these complications are like the common complications which we have, which we routinely see intraoperatively, the complication which can present early, less than 2 weeks, or the late complications. Then I will be covering some uncommon complications, and then I will be covering some complications which you will not find in any textbook and which are usually case reports. So intraoperatively, these are the normal complications like dural tear, nerve injury, bleeding, and the wrong level surgeries. So dural tear, we know it's a high incidence, and this is like one of our case of the microendoscopic discectomy. And when you are taking out the disc, sometimes it is adherent to the dura, and the risk is higher in the revision surgery. So while taking out, you can see there is sudden gush of the CSF, and this is usually the dural tear. And incidental as well as the big dural tears, they are common in the disc surgeries. So they are often unavoidable occurrence of the spinal surgery, and if you don't repair them, then it can lead to further CSF leak, and it can lead to pseudomeningocele formation. And patient also experiences, CSF headache, and they also require increased nursing cares. So what are the risk factors? So people have shown that, the kind of pathology, if you are decompressing for stenosis and doing the revision spine surgery, so they have a higher incidence as compared to the traditional discectomy. And these are some of the risk factors which have been mentioned in the literature: age, obesity, diabetes, the type of surgery which we just discussed, revision surgeries, synovial cyst presence, surgeon's experience, and the ossified yellow ligaments. There are some risk factors. And if we just talk about the disc surgery, so if you look at this diagram, so they usually occur near the herniated disc because there are a lot of adhesions if there's a long-standing disc. So dural tear can be prevented if you are very gentle with the dissection, if you are avoiding the blind curettage and you are using microscope. So these factors, they actually prevent the dural tear. So the question arises again that how to recognize these dural tears intraoperatively, because sometimes you are not able to recognize them whether it is a dural tear or not, because sometimes excessive bleeding of the venous bleeding also looks like the CSF leak. So usually there is a spinal fluid, clear fluid, you can see that, and sometimes the underlying arachnoid membrane may be intact, so you cannot see the spinal fluid, and CSF leak can lead to the decrease of the tamponade effect on the epidural veins. So there could be an increased venous bleeding also. So these two scenarios, they can look like each other. And also always you can do a Valsalva maneuver with your ask your anesthetist friend to do the Valsalva maneuver, and you can see that the fluid start coming. So this is I was talking about, that sometimes if you look here, this is not a discectomy case, but you just see here that this is the arachnoid is still intact. So these are sort of the cases, they will not present with CSF leak immediately, but they can present later on. So how to manage these cases? So first of all, do not panic, and primary repair and the usually leads to good outcome. Prevention is the best strategy, and I recommend that the fellows and the junior colleagues, they should practice on the animals and the cadavers spines for their training. And always remember to do the operation you were there to which you intended to do. Deal with the dura and get back to the surgery. And the size of the durotomy, the quality of the repair, and the tissue qualities, they're all important factors, which determines that you are going to use the other adjuncts, drain, or the other things. You reposition the patient, CSF leak site becomes the highest point. So for lumbar spine, we keep the head down, and for cervical spine leaks, we usually keeps the limbs down. Instruments, you should have a dedicated dura repair set, and microscope as well as the cottonoids should be ready. Do not hesitate to enlarge the exposure, if you are not able to see the dural rent. And if you have not seen the extent of the dural rent, so that remains the most common cause of the unsuccessful repair. Always look for intradural hematoma or the bone fragments, and if there are the some nerve roots they are coming out, carefully avoiding suction, just keep these the nerve roots inside the dural defect, and then try to close the dura. And primary suturing, the gold standard, Prolene 5 or 60 is the best, and running lock suture, they are better than the simple interrupted sutures. And this is one of the paper which have shown that the 60 Prolene using is the best, the candidate for these repairs. So a watertight closure is the best insurance, and if you are not able to do that, then also supplement with the fibrin glue or the Tissile, or you can use the Duragen. So this is the commonly used Tissile. So it's basically a combination of the freeze-dried fibrinogen and the thrombin. So we mix them, and then it immediately forms the clotting factor cascade and the do. This is one of our case in which we repaired the dural leak. You can see that we have repaired the primary, and then we are using this Tissile to repair this thing. So gel form should be avoided because its manufacturer brochure itself says that it should not be used inside the canal, and you can be in medical legal issues if you're using this thing. Always do the Valsalva to check whether the leak is there or not. And if no leak, then the repair is effective. You can always put some dye also if you are in doubt. And also you should do close your fascia very airtight, and compression dressing should be applied to increase the adherence of the suture in the first few days. Post-operatively, some people use superficial drains. I don't use it. Prone positioning with foot end elevation. Again, if your repair is watertight and this thing, it is not required in my practice nowadays. Bed rest, we can give it for up to 24 hours. And some people use acetazolamide, stool softener, fluid therapy, and analgesic, and I don't see any harm in prescribing them. So they remain the part of my protocol for 24 to 48 hours. So sometimes they are difficult dural tears, like in lateral position, the ventral and root axilla, along the root sleeves. If there is a paper thin dura, especially in Angst cases, they usually don't hold a stitch. In those cases, again, we have to think of something else. And I will be just describing the technique which we use. If there are sharp bone edges, sometimes you don't see them at the time of surgery. So if there are sharp bone edges, sharp instruments tearing the axilla, so again, there remains difficult problems, and this kind of the pseudomeningocele formation can be seen in these cases. And commonly post-operatively you see a palpable fluid collection, and if in doubt, you can aspirate and you can send it for beta 2 transferrin levels, which are very specific. And clinical signs like postural headaches, tinnitus, nausea, vertigo, they also again very the corroborating signs. You can look for ultrasound and CT myelo and the MRI to look for the diagnosis. And if there is so much such picture, you can always aspirate it to confirm in the operating theater whether it is the CSF or not. So you can always extend the dural tear if it is not repairable, and then carefully looking at the overall anatomy and the defect, then you can repair it. Then you can use this muscle or the fat patches, and then you can always supplement it with the fibrin glue or the collagen matrix. This Duragen Plus is I think this is by the Reddy's company. So this is actually very useful for these difficult the dural tear, and this is actually collagen mimetic tissue. So you can use it as an onlay graft, and you can use this sandwich technique that first put these the Tissile, then put these the Duragen, and then again put the Tissile. So it gives a very good the outcome. So this is one of our case in which we are putting this thing, then we are putting the Tissile over the top of that thing, and we are closing the defect. So my practice, small durotomies, we repair with 60, no superficial drain, flat overnight and slowly mobilize. And if there is a tenuous repair, then we escalate them. So this is a kind of, you can say that you can take stairs, or you can straight away go to the lift depending upon the type of the pathology. If there's a persistent CSF leak, then you can always involve a senior surgeon, re-explore, consider the placement of lumbar drain and the lumbar peritoneal shunt. Nerve root injury is again a very common intraoperative problem, especially in the learning curve of the people. The causes could be like traction or the misidentification. The outcome is obviously the deficit and the neuropathic pain remains there. So, if the real causes can be like excessive root destruction, or thermal injury can be a possible cause in bipolar or the endoscopic RF cases if not properly handled. Double nerve root is again, is again a pathology which you should be, aware that sometimes these, nerve roots, they can be, the aberrant nerve roots, and this could be one of the cause of the nerve root injury. Neuromonitoring has got limited role, and it can be useful in complex and revision cases to identify the nerve root. Wrong level surgery is a serious, the no-go, and still occurs in the experienced hand. The transitional vertebrae, they are traps, and you should be extremely careful when you are dealing with these surgeries, and always use the intraoperative fluoroscopy to confirm the level, and timeout with the, your staff is again an important strategy. Bleeding again is a serious problem if in all sort of the type of cases which you do in these cases. And again, you should be using all sort of the armamentaria like bipolar, or these the gel foams, or the IV tranexamic acid and BP to manage these cases. Usually they can be easily managed with these cases. Post-operatively, early complications can be like hematoma, infection. Again, CSF leak we have already dealt with. Epidural hematoma is quite rare, but if there is a rapid neurodeficit in the post-operative period, it's again, you should think of the epidural hematoma. And emergency evacuation within 6 hours is the best outcome. Infection, again, superficial versus deep, and usually staph is the most common culprit most of the cases. Again, the prevention is the key, and we know the steps to how to prevent the infection. So I'm not going to detail. But if there's a discitis, these patients usually present with severe pain and high ESR CRP, and pain out of proportion must never be ignored. MRI is diagnostic. Often it is subtle initially, but if the CRP trend is rising, then you should think of. And low virulence organisms, they are frequently underestimated. So normally, if you have a doubt, you can always go for a biopsy. 6 weeks IV plus 6 weeks oral usually remains the standard, and surgery only if there's instability and the abscess formation is there. So this is one of the case, which we did the microendoscopic discectomy, and this patient had, developed discitis. And then he was managed with this is the contrast imaging which showed the infection, and this managed with the biopsy, and the overall, we give the appropriate antibiotics, and it was settled with the fusion later on. The auto fusion was there. Late complications can be recurrence, instability, and the failed back syndrome. Recurrence, Arjun already told you the risk factors, but the annular defect remains the key factor. Large annular defects, again, remains a significant risk factor. If there's a minimal instability, then you can probably proceed with repeat discectomy. If there's a large defect and facet compromises there, then probably fusion is a better strategy, and this should be tailored and not protocolized for each patient. Instability is if you are like lateral disc is there, facet over resection, then in these cases, again, you should consider the fusion. Failed back surgery syndrome is again multifactorial. Psychosocial component should always be thought of, and correct indication is more important than the technique, and never operate MRI, always operate the patients. Epidural fibrosis is again a pain generator. You should think of a contrast MRI in failed back syndromes. Enhancing scar versus non-enhancing disc should be looked at. And if you're going to re-explore, then it worsens the fibrosis and is a major contributor to FBSS. Arachidonitis is again, you can see like the empty sac sign where all the nerve roots are they stuck inside. One of the common questions asked by my fellows is that what is the difference between arachidonitis and epidural fibrosis? So epidural fibrosis is actually outside the dura. So it is scar around the nerve, while the arachidonitis is actually scarring inside the dura. So all the nerves, they are stuck together, and it usually causes severe neuropathic pain, and surgery is rarely beneficial in these cases. Now, coming to rare complications, great vessel injuries, again, is this rare, but it still happens. It may present delayed as hematoma. Immediate vascular control is critical. I have heard and have, heard the people, the losing patient because of this great vessel injury, and it requires a team preparedness. Visceral injuries again have been reported in the literature, and majority they are small bowel. The large intestine are rare, and this is one of our case, and which had the bowel injury, delayed bowel injury, and you can see here that we have published that this anterior disc herniation remains an important, the factor which should be looked into these cases. That if you see this anterior disc herniation, it shows that the ALL is incompetent, and then if you're going for interbody fusion, especially in these cases, then you should be very careful that you have this in mind, that you are not going anterior because this ALL is deficient. And this patient required, the anterior approach for the bowel repair, and then she developed hernia. Then again she underwent the hernia repair. So patient has a very the bumpy ride towards her recovery. Now I will be telling you some complications which are not in textbook. So instrument breakage is again one of the complications which we have encountered. Like this was one of the case which the disc, the discectomy forceps broke inside this thing. So and this is one of the most dreaded complications, which I have seen. I've seen 3 such cases in my life where the knife actually, the broke inside this thing. And if you see this X-ray, there is a knife, the breaking inside, and you believe me, it is hell of a problem to remove this blade, because you can't see anything. Even under microscope, you're not able to see this thing. And the more you try to take it out, it actually moves forward. And in this case, actually, we have to take out so much bone and this thing, that actually we have to resort to TLIF. When we were able to take out, we had to remove so much bone because it's sharp, this thing, we can't leave it inside. And then ultimately we had to do the TLIF. This was another case which, again, the knife broke, and then, we could not retrieve it, and actually it moved forward. And when I called my vascular surgeon, and he actually dissected everything, and he just put my finger inside below the aorta. So it was just tenting the aorta. So, we just put our finger between the blade and the aorta, and then we just, with the help of a disc forceps, we just take it out, this thing. And this is the intraoperative pictures. You can see these broken knives. And this is one of the other rare complications which we have seen in this surgery, is that the patient woke up with severe headache after the surgery. The surgery was uneventful otherwise. And then we get the CT scan done. And if you see this CT scan, you can see that there's air. There was a pneumocephalus, and we had no explanation for this thing. People have said that probably an inadvertent dural tear, or if you are giving too much pressure oxygen, it can lead to pneumocephalus. But the surgery was uneventful otherwise. And this patient, with just by conservative management, he recovered within 4 weeks. And this is the post-op, the post 4-week scan, and it showed no pneumocephalus after that. So medical legal aspects, they are again important. Always consent, document, and have the imaging proof. I always send the disc material for histopathology to confirm that whether that I have removed the disc material. Otherwise, sometimes I have seen cases where the people have the sued doctor for recurrent disc herniation, that the surgeon has not removed the disc in the first sitting. So always send the disc for histopathology. Good surgery protects the patient, but the good documentation protects the surgeon. So complications define the surgeon, not the surgery. Anticipation is more important than the reaction, and mastery lies in management, not in avoidance. Thank you.
Thank you, Bauk. I think it was exemplary. You really covered a lot of issues in spine surgery and surgeon's life. We just would like to ask KV Menon sir his words of wisdom on this topic.
Nothing much to add. I think he's covered virtually everything there is in terms of complication.
Thanks. So I also have encountered this, what you showed about the breakage of the tip and the knife in the disc. It's really a challenge, and it's a nightmare at times to remove. You can't see it. Even if you're seeing it in C-arm, you can't touch it. Then you have to do wide decompression, wider exposure, and it's a challenge. I think in want of time, I would like to request Dr. Parasnis to head on the last important topic before the review of literature. Over to you, Dr. Parasnis, on revision scenarios in disc problems.
Thank you, Shailesh. Are you able to see everybody?
Yeah.
Yeah. So this. 1 second, please. So this was a patient, 46-year-old IT professional, came with extensive radicular pain, no response to the conservative treatment, in spite of almost 5 weeks, marginal EHL, grade 4 problem, but his main problem was inability to stand, walk, do daily activities. So he was promptly advised discectomy, which was done endoscopically. He did fine, went home the next day, absolutely fine till suture removal. 1 second, please.
Can you just enlarge? It's on the right.
Yeah. Yeah,
lower
but
side. Yeah.
are you able to see? Yeah. So he was fine. Then he came back with recurrence of pain for 3 weeks, acute pain while getting up. It suddenly started after going to toilet and straining. There was no relief with simpler medicines. We told him on the phone. Then he came for follow-up, unable to stand and walk. Neurology was intact. So we did his X-rays, also the X-rays to find out any instability because he was 91 kg, having pathological obesity, and this was his follow-up MRI. So anybody wants to comment?
Yes, would like to ask Dr. Arjun.
MRI, can we show the MRI, please?
So MRI, you're not able to see the MRI?
No, I can't.
Let's go back to the previous one, Rajesh.
So this was the X-ray. Can you see the MRI now?
No, the slide is not moving, I think, Rajesh.
Rajesh, I think it's sharing the PowerPoint and not the slideshow. I don't know why.
What about now?
It's
I
still
think
Now?
showing us the PowerPoint picture, not the slideshow picture.
Hmm. Should I just go back and do the whole thing again?
Yeah,
1 second.
Yeah.
What are you able to see now?
yeah.
Yeah,
Just
very,
you need to enlarge it now.
yeah,
No,
now we
once
can
I
see.
enlarge, it's going. So if you can see it,
This is okay.
difficult?
We are fine. Yeah.
Yeah. So this is the MRI, almost 4 weeks from the primary index surgery. Radicular pain, no deficit. Significant pain, no relief. 91 kgs, IT professional. So Arjun, when do you advise MRI if the patient comes back with recurrence from the primary surgery, or you have larger threshold for accepting and treating conservatively?
If the patient has recurrent symptoms and significant, then definitely it's worthwhile getting an MRI and understanding what's going on. I mean, it depends on if it's a mild tingling or the patient has severe radicular pain. I mean, if it's just very mild, pain and then patient is okay, I would give a short course of pregabalin, see how the patient is doing. But if the patient has significant symptoms, then definitely I'll have a low threshold, get the scan done, be clear about it. Very early MRI, it becomes difficult to interpret, but should be advised with contrast.
Yeah.
But otherwise, I
So-
would get it done.
So in this MRI, there is no ambiguity. There is a large
Yes, it's
compression
very clear.
state,
Yes.
maybe a recurrence disc, and patient
Yes.
already had come with a lot of ChatGPT and Perplexity reviews, looking at the MRI picture, very smart IT professional. So he came and asked me, what is the way out? How do you tackle and what do you advise?
For this patient, I would recommend, discectomy. I would it's very clear the compression is significant.
Yeah.
And I think either there is a fragment which is re-extruded, because if the patient had improvement initially and then has a recurrence, maybe some fragment has come out from the annulus again, or which is most likely, because the patient did have some short-term relief and then had a recurrent episode.
I just would like to add up. We have published one article about residual, recurrent, retained, and remnant disc. So residual is something which is remained. You tried to do a decompression, but it remained. Retained is you have retained it supervised, that you just did a foraminal decompression or a posterior deroofing. Recurrent is a new disc which is come, and remnant is a small portion of the disc which is remained, and it is become a bigger one. So these are the things, sometimes we don't realize. And when we do the decompression, we always feel we have done a good job, but sometimes we need to understand this in a better way. Or yes, or do you, Raj?
Any role of root block injection here, Babu?
Not for this patient. Not for this patient. This is a large disc. It's there is a large extruded fragment. It's sequestrated also. I would offer this patient a repeat discectomy. If it was a very smaller disc, then I would probably consider that. Here you have to address it and deal with it. But if it was a smaller disc, then that would be the next step usually to follow.
Yeah.
Okay. And the decision whether just a decompression and fusion, what are the criteria that you see that you already mentioned? But if the patient is overweight, high BMI, or professional requirement, does it have any bearing?
Yes. So if the patient, is involved in, say, suppose he's like a manual laborer, has to lift heavy weights, etc., then I would offer fusion. If the patient is obese, like an overweight guy, very high BMI, then again, maybe fusion would be a better option to prevent a recurrence, and and if there was, like here, I don't think the facets are, frankly, that unstable. I think the tropism is there, a little bit facet fluid, but I would probably be able to offer a discectomy. It's only a few weeks, so I would offer a discectomy again.
Excellent. So we went ahead with a tubular revision microscopic decompression. Partially, the IAP had a medial facet which was fractured and we removed it. So we are very apprehensive post-operatively whether the patient will come back with issues. But fortunately, till so far, he's doing absolutely fine. So this was a case to show that every revision need not be stabilized or fused. You can very well do a repeat minimal invasive decompression also with excellent results, provided there is no instability or any signs. So the second case, this was a 35-year-old guy who walked into my cabin. I had operated him 17 years back with a L4-5 and L5-S1 decompression back side. He had severe pain. I don't have the initial imaging. This was a recent one where he had a right-sided foot drop, he says, since last 12 years. He also has got severe pain on the right side predominantly, left side mild, and probably claudication for some time. But he says he never used to walk, mild BMI increase. This is his MRI. You can see, yeah, right? So you can see that he has discs at all levels. He had significant compression on the right side L4-5, right side L5-S1, left side L3-4, and a central plus left side disc L2-3.
Yeah.
Sorry. Can I just go ahead and go to the other case?
I think go ahead. Yeah, go ahead, Rajesh.
Yeah. Shailesh, mic jumbling. So this was a patient. You can see the L4 laminectomy and partial 3 and 5. This was pre-operative. This guy was operated 17 years back. Now has come with this, and these are his axials. You can see a large foraminal L4-5, right-sided, corresponding to his deficit and pain. Also, L5-S1 right-sided, there is a posterior calf pain, but no S1 deficit.
And 2-3.
L3-4 central and large, and 2-3 also very large and left side.
Yeah. The multi-level problem.
Yes.
Yeah, I want to just add one thing, in our place, if the patient has earlier operated for any reason, we always get a contrast enhanced MRI, because the scar can always look like a disc, in a previously operated case. So it is always better to get a contrast enhanced MRI because scar will enhance diffusely while the disc will not enhance diffusely.
So gadolinium contrast for postoperative MRI should be a gold standard to differentiate. But Bhavuk, this was 17 years back, the surgery was done. And radiologist did not ask me for contrast because everything was delineated very well. So probably there is a time difference. Immediate post-op or even subacute stage, you need that. Very prolonged, you may not. But if the radiologist calls you and feels that the contrast is going to give you more information, you have to do it. Now, one more thing in this imaging, there was bony canal stenosis. Do you all appreciate that? Very short pedicles.
Yeah.
And multi-level disc degeneration. So this is not a run-of-the-mill single-level lumbar PID. This is a complex issue. So anybody, any takers, what would you do in such cases? Bhavuk?
So this will require fusion, obviously, because for adequate decompression, you will have to take out too much bone. So this will, invariably will lead to instability. So I will go for fusion.
Is Appaji there?
Fixer.
Fixer.
Yeah, I'm here.
Yeah. What will you do?
So do you agree with multi-level fusion, or in these cases you have some different criteria?
No, I will follow the principle of fusion only in this.
Levels?
2 level.
Which levels would you advocate?
L4-5 and the L5-S1.
But the Appaji, there is a L2-3 severe stenosis with a large disc. Can you see that?
No, but that looks.
Very severe stenosis, very, very small dural cross-sectional area.
Yeah. But yeah.
And he has bony canal
saw
stenosis significant.
Yeah.
And the other problems is the expected ADD. If you fix 3, 4, 4, 5 within a short duration, this gentleman may come back. He's just 35
Yeah.
right now.
Yeah.
Right.
No.
Abhay is
I
there.
missed that.
Abhay,
I
what
missed
will be
that.
your plan?
L23. I missed that. So, I mean, what was his clinical symptom specifically? Thigh pain.
Claudication, acute radicular pain right-sided foot drop, and claudication for many years, and mild left-sided pain.
Oh, I'll do a multi-level fusion.
Yeah, I agree.
So I'll just go forward and
Yeah.
show this is what we did just recently,
Yeah.
still indoors. Right?
Yeah.
So sorry about the sequence. I'll just go back and show this case. Now this guy was a young gentleman, around 19 years old guy, college going, adolescent disc, was conserved for a long time, almost 3 to 4 months, kept on coming back for pain. This was his appearance, foraminal disc, 4-5, mild EHL weakness, significant problem, and taken multiple opinions. Everybody advised surgery. So we also complied and did the surgery, went very well. He was in vacation, 1.5 months down the line, he comes back with pain. 3 months later, it became severe. Radiation along the same side of operated, more on walking, prolonged standing. His main complaint was whenever he goes to the college and sits, there is pain, and it was not getting relieved. So we repeated this. Now the MRI showed a cystic disc swelling on the operated side and bulge, diffuse, and foraminal compression. What would you do, Shailesh?
No, I think, yeah, again, it looks like probably a small synovial cyst. There is some moment which is occurring in a young guy, and probably this is looking like a facetal small cyst along with the disc. You've done a first decompression, but this is not uncommon. So I think if he's with persistent pain, the pain is not settling, and he's unable to sit in the college at 3 months, I will consider revision decompression. Probably I will check with the dynamic X-rays, and if he's having significant back pain, then only I will consider fusion. Otherwise, I will consider re-decompression for a young guy.
There was no back pain. There was no instability. There was instability pain while changing.
Re-decompression. Midline is intact. Everything is intact. We can still go a bit far lateral, and you can do it. Yeah.
Arjun?
I would give a block once, see if the patient settles. If the patient doesn't settle with the block, or patient has short-term benefit with the block, then I would offer the treatment.
Yeah. So we were surprised to see the cystic swelling. So we went back and analyzed the first MRI, spoke with the radiologist. There was no communication with the facet. So probably this was one of those subannular cystic collection, or you do a lot of lavage during the procedures. That's why. So, and fortunately, whenever we asked the patient to consider block or decompression, there was a lot of resistance from the parents. We also had a sense that the guy was not very keen to attend college. So there was a variation in the kind of symptomatology and the complaints. So whenever we are treating pain, and 90% of the times we are doing discectomy for pain, I think the personality component is also something that we don't discuss. So the age, weight, professional demands, the activity levels, individualized problems, and the personality play a role. Now, during this course of conservative treatment, we added teflazocort. Surprisingly, the patient himself came back and saying that he had a relief because he wanted to attend a marriage in Udaipur, and then suddenly his pain went away. He came back. We also became cautious. Now, a few months down the line, is absolutely fine. So this is also to say that sometimes you should have a judgment of the patient symptomatology and the pain intensity, and it becomes easier if you are the primary surgeon. So you want to comment on this, Shailesh? Will the protocols be same for everybody if you are the primary operating surgeon and somebody else?
Absolutely. This is the best thing, because clinically, when you see the patient, you can make out. That's very important. There were clinical and clinico-radiological correlation. When we are just seeing on webinar, we are just seeing pain and back and leg pain. But when you see the patient, you can immediately make out what is exactly happening. You see the tension signs. You understand. You see neurodeficit. you decide. So surgery is always the last thing in such scenarios, and also psychological factor. What they call is occupational health hazards are quite a lot in Western world, because people who just want to tell that I'm not better, MR is okay. But these are the things which are coming up in India also, and this is we are also experiencing this. So patient's evaluation and discussion dialogue with the patient is very, very important before deciding anything.
Dr. Menon, sir, how much is your threshold to accept recurrence pain or recurrent disc in such cases? Do you advocate surgery with certain criteria of yours, or you give a wider margins compared to the primary conservative treatment?
So my threshold for surgery is pretty high, particularly in a recurrent disc. And because there are 2-3 issues. First of all, the question which you mentioned earlier was, does he need a surgery at all? So I almost always give an SNRB or an epidural or a foraminal block or something of the sort to make sure that he does have no other solution but a surgery. That's number one. And the second thing is whether a fusion is needed or not. So I tend to depend on Andrea Simmons' criteria that was published in the Journal of Neurosurgical Review a couple of years ago. You have to have significant back pain on the clinical front besides the leg pain. Then in addition, you have to have certain features on the plain X-ray, which is a very large disc space, which means that the disc space is narrow. That means with osteophytes, that means it's a spontaneously stabilizing disc. But if you have a large, wide open disc space, that means it's potentially unstable. Flexion extension X-rays, and on the MRI, recurrent disc, synovial cyst, facet fusion, all those criteria have to be there for me to undertake the fusion. So I would look at multiple criteria. Is a recurrent repeat surgery required? Can I get away with a block or a injection? If not, if surgery is indicated, what surgery? Is it a revision disc or a fusion?
Yes, sir. So last case, Shailesh, this was a lady,
You are
42-year-old.
rapid fire, yeah.
Yeah, just last one.
Yes.
So April 24, I saw her first. She came with history of surgery 9 years earlier and a large scar. This was the MRI. She did not have any kind of imaging prior. This was the X-ray. I was very surprised to see because her operative notes, even though the imaging was not done, was suggestive of only a disc for which this was done. And she kept on getting some amount of pain post-operatively, which worsened 3 years later. 9 years down the line, it was severe. So we conserved. She again came back in June 24 with another MRI done elsewhere. This was the picture. Now, with the high resolution MRI, there was some hyperintensity in the disc. You can see that track. We still tried to go into detail if there is any instability, but there was no evidence of screw loosening. But she kept on coming back with gluteal pain, with back pain, with radicular pain.
Right sided.
And most of the time it was right sided, but twice she also came with bilateral pain.
Okay.
Right? So this was the picture on flexion extension. You may say there is a mild movement, but there is no gross instability per se. But she kept on getting this kind of pain which was there. So recently, again in September, she came back. Again, MRI was repeated elsewhere, and this was a picture. Just localized back pain in the operative area, radiating more on the right side, left side sometimes, also claudication, and just unhappy patient which was miserable. So what is it that would you advise? We'll just take a rapid fire. Arjun, Bhavuk, Shailesh, everybody.
Yeah, pain block, psychological counseling.
Yes. So twice we repeated facet block, middle bundle branch block, as well as root block. She had a relief for 7 days substantially, then again recurrence of pain gradually, and 3 months down the line, more severe pain than before.
Probably she will need re-exploration, facetectomy, and interbody at 4-5.
So how do you explain, based on the pain regenerators and the explanation, in spite of stabilization and no further new disc prolapses, how do you explain the amount of pain?
Some amount of, even if it is, so it is long-standing, but we can see that the right side foramen is quite significantly compressed. That is probably the reason where she's getting the right leg pain and claudication. A young patient with persistent pain, not settling with pain blocks, everyday pain, otherwise psychologically counseled. Something is missing in that, yeah.
So how do you counsel such patient? Bhavuk, what do you tell preoperatively if you embark on a revision surgery?
But I think there is some sort of fibrosis there. I can see that the muscle fibrosis is actually going inside the canal. So probably there is a component of epidural fibrosis as well in this patient. And I will certainly ask for contrast-enhanced MRI in this case.
Right. Arjun, any comment?
I will also get a
final plan?
CT scan. Also get a CT scan here, because there is instrumentation just to be sure, I think that one screw is a bit long also.
Yes,
You know.
the lower one, L5.
Yeah.
We
Yeah.
didn't get the CT scan. This was the final imaging just prior, again repeated. So we went in, we did this. As Bhavuk has said, there was extensive fibrosis. Even the muscles on that side was also probably replaced by fibrosis. We had to separate it very carefully. There is no role of being very minimal invasive about this. We had also counseled if the bone stock and all, everything not appropriate of revision, we might have to go above, below. So, and we also explained that the surgery is only done to stop the progression, reverse some amount of pains which have been recently, but she might have residual neuralgic pain. Fortunately, she has shown substantial improvement in the radicular pain and claudication. Some amount of back pain remains on persistent sitting, but she has done very well. So this case tells you that, fusion in a disc surgery is not a panacea. If you want to fuse, do a 360-degree job, but in spite of that, the patients may require certain revisions or may come back with recurrent symptoms. Thank you, Shailesh. Back to you.
Perfect, Rajesh, for a beautiful demonstration and variety of cases. We move on to the last quick
Shailesh,
view of literature.
can I ask a question to all the faculty members?
Yes.
I have operated some cases, in which I have seen that there was a protrusion on the MRI, and when we opened, actually the disc was bulging, and when we give the nick, actually just like sort of air sort of pop was there, and there was no fragment. Has it happened with you or the other faculty members as well, or
Yes.
there was no fragment, just
It's like an annular bulge, and you
Bulge,
try
yeah.
to explore because you're gone in and you want to see, but this has happened a number of times.
This happened with me also, yeah. Okay, thank you, Rajesh. And we move on to the review of literature. Over to you, Dr. Akash Singh Bali from AIIMS, Delhi. Akash.
So is my screen visible, sir?
Yeah, correct.
Good evening. Good evening, respected faculties and my senior colleagues. I would like to sincerely thank the ASSI committee for the opportunity, and a special thanks to Dr. Shailesh for letting me present here. As we are at the end of the session right now, and all of the stalwarts of the spine surgery have already discussed in detail the aspects of lumbar discectomy. My job is very simple, and just to review the literature in terms of the outcomes in lumbar discectomy surgery. So coming on to first of the evolution of the surgery, we have come across from the open laminectomies to the open discectomies to the micro discectomies and outer tubular discectomies, and the most recent advances of endoscopic discectomies. This is image of showing what we want minimal damage, and this is just a pictorial demonstration of the same. I would like to keep it short. I went into the review of literature and found out some good articles published in reputed journals, Global Spine Journal, Journal of Neurosurgery, and a recent article in Neurospine in January 2026, which is now asking the question, is endoscopic discectomy the next gold standard for lumbar disc herniation? Although it's too early to tell that, but comparative studies and long-term outcomes of the VAS and ODI scores across all techniques, that there is the micro discectomy, which is the gold standard currently, and the tubular technique and the endoscopic technique have yielded good success rates about around 85 to 95%, with added advantage of endoscopic techniques of less blood loss, less hospital stay, early return to work, which is approximately 2 to 3 weeks, and less muscle injury, as has been documented by low levels of CPK and CRP in comparative studies and the systemic reviews and meta-analysis. Although the statistical significance in terms of doing an endoscopic surgery is better, but the minimal importance difference is not just significant as of now. In the complication rate, the recurrence rate, the reoperation, the three procedures. And however, some of the articles in the past, around 2020, the Journal of Neurosurgery article by Beryl told that dural tears were higher in open as compared to endoscopic surgery. However, the gold standard is currently the micro discectomy. However, tubular and endoscopic provides us faster recovery and less tissue damage, and is leading the early recovery for the patients. So keeping it short, the take-home message will be that technique does not determine the outcome. It is overall the surgeon's experience, the indication which leads the successful outcome. And the final take-home message from my side would be endoscopic is improving recovery and not the long-term results. More studies are needed to show this benefit. However, I feel like the transition from open appendectomy, open cholecystectomy, there is the transition to the laparoscopic one. I feel in the future, maybe it's too early to say, but in the future, I feel the spine surgery go more towards the endoscopic era, and we are maybe in presently we are doing in such a area, such a era itself. That will be my take. Thank you, sir.
Thank you, Akash, for a wonderful presentation. And I think you covered all the aspects of the discectomy surgery and the review of literature. Ultimately, the cell indications are very, very important. Right indications, a good surgery, though it is microscopic or tubular or endoscopy, outcomes at 2 years are almost good. Yeah, in maybe endoscopy, early return to work or the activities of daily living are slightly faster because less muscle damage and soft tissue. But ultimate is how good the patient gets benefit of this. And thank you once again. I really would like to thank all the esteemed speakers and faculty, also Dr. Parsha and Dr. Akashdeep Bali for your time. And I would request Dr. Bhauk Garg and Dr. Fanikaran to say a few words before we stop this. Yes, Bhauk.
So I think if I have to choose, the which surgery is the most difficult surgery, and the easy but the chance of complications is high. It's the disc surgery. One has to be very careful. The small surgery can lead to the bigger complications. So don't take disc surgery as a simple surgery. It is a technically demanding surgery, and if you are not careful, then the complications, the risk can be very high. So and also important thing is that the look carefully your indications, and if a procedure doesn't make sense with the open surgery, it doesn't make sense with the minimally invasive technique either.
Yes, Dr. Funny.
Yeah, so I think Akashdeep summarized it very well, that one needs to try conservative management always, and then keep the surgery as a last option. And all these early the new techniques of endoscopic and surgeries are all only having initial immediate post-op benefits. The long-term results are not different. And the most basic surgery one would learn in spine surgery is a microdiscectomy, but that is also the same procedure that has quite a lot, significant high chances of creating problems, especially in the early years. So one needs to be careful and select the cases properly. I think it was a good session throughout. Thank you.
Thank you. Thank you. I would like to request Dr. Rajesh Parasnis to say a vote of thanks.
Thanks a lot, Shailesh and Dr. Abhay. This is an excellent endeavor you have undertaken, and even at this age, it is really a joy to listen to stalwarts like Bhavuk and so many others who have really, really brought forward different aspects of understanding the pathology of the disc, approaching the management, and also about the post-operative issues. Dr. K.V. Menon, sir, always it's a great to have him for his experience. Dr. Panikaran, Dr. Arjun, and Dr. Akash, as well as Dr.
Partha.
Parthasarthi. It was great to have all of you over here. Parth also has given his bit of wisdom about the historical things, and all of you have brought out the different aspects. And it is just underlining one simple fact: we are all students, we are still learning, and it is great to have this kind of discussion. So, all the best, Shailesh and Abhay, and I'm sure this will have more and more following, and it will contribute to the knowledge of each and every spine surgeon in India. Thanks a lot.
Thank you once again to all the viewers all across globe and India for giving us this opportunity. And we see you next month, June first week once again. Good night, good day, and thank you once again. Bye. Thank you. Recording stop.